Good afternoon, everybody. Thanks for joining us today in our cardiovascular grand rounds. Welcome, Dr. Achenbach, and thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce you to our moderators for this event. Dr. Jaime Cabrales, Chief of Hemodynamics and Interventionism, and Dr. Hector Medina, Chief of Cardiovascular Imaging at La Cardio. Welcome, and thank you for moderating this event.
Bueno, buenas tardes a todos. Muchísimas gracias por asistir a la primera sesión de Grand Rounds del año. Tenemos hoy el honor de tener al doctor Stephan Achenbach acompañándonos. Le recordamos que al conectarse a esta conferencia autoriza el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 de 2012, nuestra política de datos personales, la cual puede consultar en www.cardioinfantil.org. De igual forma, le informamos que esta conferencia será grabada. El chat de preguntas se encuentra habilitado en la barra de participantes y les agradecemos dejar allí sus inquietudes, las cuales resolverá el doctor Achenbach al final de la sesión. Un agradecimiento especial a Siemens por vincularse como patrocinador exclusivo de esta actividad. Hoy tenemos el gusto de tener al profesor Stephan Achenbach con la conferencia Past, Present and Future of Cardiac CTA to Optimize Diagnosis of Care of Cardiovascular Patients. El entrenamiento del doctor Achenbach incluye Medical School en la Universidad de Friedrich Alexander en Alemania, entrenamiento en medicina interna en la misma universidad y un Research Fellow en el Departamento de Radiología en la División de Cardiología en el Massachusetts General Hospital. El doctor Achenbach fue el presidente fundador de la Sociedad de Tomografía Computarizada. Dr. Achenbach was the founding president of the Society of Cardiovascular Computer Tomography from 2005 to 2007 and served as the vice president of the European Society of Cardiology from 2014 to 2016. He's currently the chairman of the Department of Cardiology and professor of medicine at the University of Erlangen in Germany, and also is the chairman and the president of the European Society of Cardiology. Dr. Achenbach is among the 1% most cited researchers in the field of clinical medicine, and he has authored more than 150 publications listed in Medline. Welcome, Dr. Achenbach. It's a real pleasure to have you on board and having you as our main speaker of our first session of Grand Rounds, and it's really an honor and a privilege to have you lecture us. Thank you so much.
Well, thank you. It's a pleasure to speak to you. Thank you for the invitation. I also consider this a big honor. I hope you can hear me well, and I can hope you can see the screen. I've been given a big title, the past, present, and future of cardiac CT for optimizing diagnosis and care in clinical cardiology. So that's a really, really big topic, but I'll try to focus on a few points that I would like to make. So I think we all know and realize what cardiac CT is able to do these days and the tremendous image quality that is possible, particularly for visualizing the coronary arteries. Most colleagues will immediately associate cardiac CT with visualization of the coronary arteries, non-invasive coronary angiography, as it's called, but CT can do more, as we will see in the next several minutes. And if we take a step back to think about why CT is so exciting to visualize the heart, and what makes CT different from the other non-invasive modalities that we have, it's good to look at the properties of CT and how CT acquires the images. So modern CT systems, there are all kinds of high-end CT systems now. When they are used to visualize the heart, cardiac CT, typically these systems will acquire approximately 300 very, very thinly spaced, thin slices of the heart. Typically takes a few seconds. The temporal resolution of the in plane of the individual image is approximately 100 milliseconds, and images are synchronized to the patient's EKG. And this allows for very high resolution imaging. This is a typical cross-section that is acquired with the high-end CT, very high resolution imaging, and if it is done correctly, also free of motion artifact. And you can see the very small and thin structures such as this normal aortic valve, the mitral valve, and of course, you can also see the coronary arteries. This is the ostium of the right coronary artery taking off with some calcified plaque. Here you can see the pericardium, a very thin line. And this illustrates the high in-plane spatial resolution. The individual slices have very high resolution. The resolution is approximately 0.4 to 0.5 millimeters. Now, the important point is that these slices are very thin. The distance from one slice to the next and the slice thickness are also approximately 0.5 millimeters. That might be 0.6 millimeters or 0.7, but with the high-end CT, the slice thickness is also approximately 0.5 millimeters. So we have 0.5 millimeters resolution in the image. And because the images are very thin, and they're all synchronized to the EKG, so they all show the heart in the same phase of the cardiac cycle, we also have very high through plane resolution. And because it's and resolution orthogonal to the imaging plane is pretty much the same as the resolution in the imaging plane, this is why CT allows to reconstruct images in any desired spatial resolution. This is what we call isotropic resolution. The resolution in the imaging plane is pretty much the same as the resolution through the imaging plane. So in the end, CT gives you a volume of data, and you can reconstruct images and look at the images in any desired orientation, and the impression of spatial resolution will be pretty much the same, no matter which orientation you're using to look at the heart. And this is what makes CT fundamentally different from other non-invasive imaging modalities. We either have lower spatial resolution to begin with, such as magnetic resonance imaging, lower in-plane resolution, thicker slices, or they don't give you the high resolution volume data. Echocardiography has very good in-plane resolution, but doesn't give you this very thin stack of slices with the volume data set. This is what makes CT really fundamentally different. Volume data with isotropic spatial resolution. Of course, this can be used to reconstruct three-dimensional data sets. This has impressed us from the very, very beginning, but this is not the essence. This is not the nature of CT. The nature of CT is that you can reconstruct images in any desired plane with very high spatial resolution. And as you can see here, if the images are acquired accordingly, even in motion, it's possible to visualize the heart. But the more important point, the motion component is not so important. The more important point is the very high resolution, the ability to see very small structures accurately in any desired plane, such as you can see here, the tremendous spatial resolution that CT allows. Now, this of course is used to look at the coronary arteries, because the coronary arteries are very tortuous structures. And if you want to see them, if you want to follow them, if you want to detect stenosis, you have to have very high spatial resolution in all orientations in space. And here's just to illustrate this concept, is one patient with a very unusual situation. This is a patient who had replacement of the ascending aorta and the aortic valve by prosthesis, and to reinsert the coronary arteries, the so-called cabrol shunt or moustache technique was used. So a Gore-Tex shunt that has an anastomosis to the left main and to the right coronary artery. And then in the middle here, there's a side-to-side anastomosis to the ascending aortic graft, cabrol shunt. And there was a suspicion, because the patient had chest pain, that something might be wrong with his coronary arteries. And the 3D reconstruction is nice, but of course we do our image interpretation based on two-dimensional images, and the images that we start with are the axial slices. And here in this slice, at the level of the anastomosis of this cabrol shunt to the ascending aorta, you can see exactly this here. This is the shunt. This is the connection to the left main coronary artery. Here you can see the anastomosis to the aorta. And then if you go a few millimeters further down, you can see that on one hand, this shunt travels towards the left circumflex coronary artery. The left main has already taken off. Here it travels downwards towards the right coronary artery. If you go yet a few millimeters further down, you can follow it further. This is exactly how these images are studied, in very thin slices, going step by step, following the coronary vessels. Then if you go yet a little further down, you can see the aortic valve prosthesis here. You can see there's a high density structure where the right coronary anastomosis should be a very high density structure. If you look inside, here is a little devil where this is really filled with contrast agent. And now to analyze this further, using additional planes, looking at this complex anatomy in different orientations is useful. So CT allows to generate slices, different orientations to generate a longitudinal view of this situation. And this slice you see has the same resolution as the original image. And you can nicely see the shunt coming down here, this high density area here, which is calcium, because there's no metal in these shunts. And there's a high grade stenosis at the anastomosis of the shunt to the right coronary artery, surrounded by calcium. And this is possible to visualize and to understand because CT allows to manipulate and create images in any desired orientation. This, in fact, is why CT is the non-invasive imaging modality that allows imaging of the coronaries, because of the high resolution throughout the entire volume of the heart and the ability to reconstruct any desired plane to visualize the very curved coronary arteries. Here's a somewhat thicker slice, which confirms the presence of a stenosis. This is the invasive angiogram, which shows the very same situation. And then, of course, since we are interventional cardiologists, this can be fixed and the patient loses his angina. So CT can visualize the coronaries. CT can visualize the coronaries and detect stenosis rather reliably when image quality is good. To achieve good image quality, a number of prerequisites are required. The high-end CT scanner, the societies officially say 64-slice CT or better should be used to visualize the coronary artery. It's easier with wider detectors, higher numbers of slices, but it starts becoming reliably possible with 64-slice CT and upwards. As far as the patients that are considered for cardiac CTs are concerned, they typically should be in sinus rhythm. It makes things a lot easier when they're in sinus rhythm. They have to be able to follow breath hold commands. They should not be severely overweight because that increases the image noise. For visualizing the coronary arteries, it's always useful to give nitrates and to bring the heart rate down because it further improves image quality. And contrast agent is injected intravenously, typically about 50 to 80 milliliters. Here's another example showing the invasive angiogram and the CT scan to illustrate another point, which is due to the cross-sectional nature of CT. When you study the coronary arteries, CT can not only visualize the lumen of the coronary tree, as invasive angiography does so masterfully. CT can also visualize, not always, but when image quality is good, CT can also visualize the plaque that is surrounding the coronary arteries and causing the stenosis. So here you can see completely non-calcified plaque causing this osteostenosis of the left anterior descending coronary artery. Here's another example of a similar situation, non-calcified plaque causing an ostial LAD stenosis. The radiation dose, if patients are suitable for low-dose protocols, can be extremely low, 1.4 millisieverts. Typical angiogram will be in the 3 to 5 millisieverts range, invasive angiogram. The amount of radiation really depends on the scanner generation that is used. The high-end scanners have lower radiation than the earlier scanners. The expertise of the investigators, the patient's body weight, and also the heart rate is very important. The lower the heart rate, the lower dose protocols can be used. In a very large registry of several thousand patients, the median dose in Germany, and that's already 9 years ago, was 3.6 millisieverts, so very reasonable radiation doses these days for coronary CTA. And if patients have, according parameters, very, very low doses are possible. Now, when studying the coronary arteries, of course, the accuracy to identify coronary stenosis is important. And this has been studied many, many times, and there are meta-analyses available that compare CT angiography to invasive angiography. And here you can see one such meta-analysis, including 30 studies and 3,700 patients. And in comparison to invasive angiography, simply morphology, the ability to identify what are called high-grade stenosis, shows a sensitivity of CT of 96%, 64 row CT and higher, and a specificity of 82%. So the specificity not quite as good as the very high sensitivity of 96%. You can also derive what is called positive likelihood ratio and negative likelihood ratio. The negative likelihood ratio of 0.022 means that if you have a patient with chest pain, he or she has a certain likelihood that coronary artery disease is present. But when the patient has a negative CT, the likelihood becomes 50 times lower that the patient will actually have coronary artery stenosis. So really, really good tool to rule out coronary artery stenosis. So, and I know you know this, I know you practice this. CT has a very high sensitivity to identify coronary stenosis. So because we have a high sensitivity, it means that a normal CT angiogram is extremely reliable to rule out coronary stenosis, and no further workup is required. And this is why CT has become such a useful tool to patients with suspected coronary artery disease. There's also very good outcome data showing that patients who have normal CT scans of their coronary arteries have extremely good prognosis and very low mortality and also very low MACE rates. So you can really rely on a negative CT scan that patients will be doing well. In fact, not only for stable coronary artery disease, but very similar data is also available for acute chest pain, unstable angina, where CT can also be used to rule out stenosis. There are also direct comparisons, randomized studies, which compared one imaging test to another imaging test. For example, the PROMISE trial, which compared in patients with suspected coronary artery disease, the use of CT versus the use of perfusion scanning, SPECT. And they could show that no matter which test is used, patients had a good outcome in both cases. So CT was not inferior and not superior to working up patients with SPECT imaging in this very large 10,000 patient study performed in the US. And there was one trial performed in Scotland, in the UK, including 4,000 patients, a little bit more than 4,000 patients, who randomized patients with suspected coronary artery disease to CT imaging as the first test versus exercise EKG as the first test. And the event rates were, for the first 2 years, were similar, but after 5 years, it turns out that those patients who were randomized to CT had a lower rate of myocardial infarction than patients who were randomized to work up without CT. And here you can see the difference, a significantly lower rate of myocardial infarction in patients who had a CT scan at the basis of the test. If you combined mortality and myocardial infarction, it was no longer significant, but for myocardial infarction itself, significant lower rate based on CT. And the idea is, and we'll talk about this a little bit later, that probably based on CT, the patients with plaque received statins, and this probably led to the reduced rate of myocardial infarction. But we'll talk about this a little bit later. And as Hector just said before the presentation started, the big societies have taken this up now. The very good data that are available regarding the use of CT in patients with suspected coronary artery disease to rule out coronary stenosis, to determine the further management. And there is now just released a few weeks ago the chest pain guidelines from the American professional societies, ACC, AHA, which give a class 1A recommendation because there are more than one randomized trials in patients who have chest pain and intermediate to high risk. In very low risk chest pain, no diagnosis statistic tool at all should be used. For intermediate to high risk patients with stable chest pain and no prior known coronary artery disease, coronary CT angiography, as they say, class 1A indication for risk stratification and for guiding treatment decisions, particularly decision whether the patient should be taken to the cath lab for invasive workup and potential revascularization. And there's also a class 1 recommendation for other testing, stress echo, PET, CMR, but not as significantly founded by randomized trials as CT is now. In fact, class 1 recommendations for both, but the evidence base is better for CT. And the ESC, the European Society, a few years ago, 2019, issued very similar recommendations which said both test strategies are possible in suspected coronary artery disease, either using CT angiography to visualize the coronary arteries or using imaging to visualize ischemia. And there's a class 1, at that time, class 1B recommendation 3 years ago, non-invasive functional imaging for ischemia, or coronary CTA with the same level of recommendation, class 1, to diagnose coronary artery disease in symptomatic patients in whom obstructive coronary artery disease cannot be excluded based on clinical assessment alone. And the ESC is using this graphic visualization along the likelihood of coronary artery disease based on clinical assessment, EKG, and echocardiography. If there's a very low likelihood, no further diagnostic testing is necessary. If there's a very high likelihood, then the guidelines say probably reasonable to take the patient to the cath lab immediately and be ready to measure if there are intermediate stenosis. But in a large number of patients with a likelihood in the intermediate range, not very low, not very high, either CT angiography or ischemia testing is possible. Across the entire range, both testing strategies are possible, but a preference for CT in the lower range and somewhat of a preference for ischemia testing in the higher range. And besides the clinical pretest likelihood ratio, also patient characteristics and preference, availability of the test, and local expertise should be taken into consideration when making the decision between ischemia testing and coronary CT. And I think that's a very important component, that also expertise is mentioned. You should do the test that you know how to do well, that is available at your institution with a high quality. And this is an important consideration. So based on what the associations, the professional societies say, there is no requirement to do CT, but there is the suggestion to use CT as one of the class 1 tools that can be helpful in working up patients with coronary artery disease. It's an option for suitable patients, we'll talk about this in a second, and clinical situations that lend themselves towards using CT. It's not a requirement to use CT, it's an option. It's not even possible in all patients. For example, if patients have very high heart rates, can't hold their breath, are severely arrhythmic, CT will usually yield suboptimal image quality. And you can predict that CT will be highly reliable when the patients are in sinus rhythm, optimally with a heart rate of around 60 or less, when they can't follow breath hold commands and hold their breath when they're instructed to do so, and when the body weight is not excessively high. These are the situations where you know that CT will be extremely reliable and provide good image quality. And this is a very, very important point where I think large institutions who have a range of imaging modalities available for whatever question have a big advantage. In saying that CTA in this case is the preferred test in patients, and so low likelihood, no previous diagnosis, and particularly important when patient characteristics suggest that there's a high likelihood of good image quality. So considering what sort of test will probably provide me with a definitive answer is a very important consideration when assigning one testing or another testing strategy to patients. And this is particularly important for CT. There are patients where we know that CT will be very good and they're candidates for CT, those who can hold their breath, those who are not very overweight, those who have a regular heart rate. And then there are patients who are not such good candidates for CT. Image quality will likely be challenging and they might be better off with another test. Image quality, in fact, it's hard to quantify, but it's important to know, is important for CT. If image quality is not optimal, if CT is performed poorly, if not adequate equipment is used, if the patient maybe was not the best candidate for CT and image quality becomes problematic, usually, and this is important to know for clinical practice, everyday practice, if image quality is poor, usually false positive results will occur. False negative results, missing a stenosis, is not the problem. The problem is that in image quality is poor, false positive results can occur. Here you can see examples of a patient who had a very high heart rate and there was motion artifact. The coronary arteries are blurred. It looks like a stenosis here, but the patient has no stenosis. This is what motion artifact looks like. Well, here's a situation that's much more difficult to recognize. There's somewhat of a high image noise. There's calcification here, and there's also, again, motion blurring. And the combination of motion blurring, high heart rate, and calcium can often lead to these artifacts which look like a stenosis. The patient has a stenosis, but certainly not high grade. And it looks a lot worse in CT. And this is an artifact based on calcium plus motion. And this A, you have to know, and B, you should try to avoid by selecting the patients and preparing the patients appropriately for the scan, because in poor image quality, false positive results can occur. And also it takes experience. For example, the experienced reader knows that calcifications might lead to overinterpretation of stenosis degree. Here, the non-experienced reader might say, yeah, no, this is a high-grade stenosis because I can only see a very small lumen, but invasive angiography shows that there's only a very mild luminal narrowing. We know that calcification leads to overestimation of stenosis, and other reconstruction tools and experience is necessary to avoid overinterpreting CT scans in the setting of calcium, particularly in the setting of severe calcium. If you look at stents, same principle. When image quality is optimal, then in-stent stenosis can be reliably detected and ruled out. But as soon as artifacts occur, the high density of the stents magnifies the problem, and artifacts can look like a significant in-stent stenosis when in reality the stent is okay. So image quality also significantly impacts the ability to look at patients who have prior revascularization. I mentioned earlier that in cases of good image quality, first of all, we continue to be impressed by the image quality that CT can achieve, but it also is the important situation where CT can be, identifying patients who have no coronary stenosis, but who have plaque. Here you can see completely calcified plaque in the coronary artery. This is the vein. This is the vein running next to the artery. This is not non-calcified plaque. There's only calcified plaque right here. A little bit further up, there's a mixture of calcified and non-calcified plaque. Yet a little bit further up, seen in cross-section, there's completely non-calcified plaque. So the CT has the ability to visualize these non-obstructive atherosclerotic deposits in the coronary arteries when image quality is good. And this, of course, is interesting because this is what is tied to the risk for future myocardial infarction. We know that the infarctions are caused by the rupture of plaque. And so basically, if you think about what CT can do clinically, if CT shows completely normal coronary arteries, even if patients might have suspected coronary arteries, when CT is normal, we know that we need no further workup, certainly no invasive angiogram, and these patients will be doing well. If patients show stenosis, depending on how severe and where the stenosis is, either you might want to proceed to invasive angiography to fix the lesion if it's a high-grade proximal significant vessel, or if it's not so certain whether this lesion is really responsible for symptoms, maybe it's not so severe, maybe it's in a small branch, you might want to proceed to ischemia testing. Or maybe if it's a lesion in a completely prognostically irrelevant branch, second diagonal branch has a high-grade stenosis, the small circumflex has a high-grade stenosis, it might be perfectly reasonable to start medical therapy and see whether the patient does better rather than doing further invasive workup. You have to make it dependent on the situation, what you do when CT shows coronary atherosclerosis. And then, of course, there's a situation, as I said before, where CT might be showing plaque. No stenosis, but definitely plaque. And we know that the presence of plaque this has a slight prognostic relevance. Patients who have plaque in registry trials have a slightly worse outcome than patients who have no plaque. There's some retrospective data, unfortunately no prospective data yet, but retrospective data suggesting that patients who have plaque in CT do better when they take statins. This was a registry of 10,000 patients. And among those patients who had plaque, the patients on a statin had a better survival than the patients who did not have a statin. While patients who have no plaque, there is no difference between those who take statins and who do not take statins. So this is indirect data that statin therapy is probably associated with better outcome. Well, we know it's associated, but probably causal for better outcome in patients who have plaque, while it makes no difference in patients who have no plaque. So the three situations that we're potentially faced with after a CT scan: completely normal coronary arteries, nothing needs to be done. Significant stenosis, you definitely want to give the patient statins and potentially send the patients to revascularization. And then patients who definitely have no stenosis, but they have plaque, there's data that suggests that statins will be useful in these patients, and we put those patients in statins very generously. There's no data that supports the use of aspirin. We know it's much more difficult to show benefit of aspirin in primary prevention. So we typically give statins in these patients, not necessarily aspirin.
It's typically a burning, tightening pressure.
So this is something we know very certainly now. that CT has tremendous value in patients who have chest pain, suspected coronary artery disease, in ESC guidelines, in ACC/AHA guidelines, both in stable chest pain, both in acute chest pain. This is a good tool that we all learn how to use to rule out coronary artery disease and guide further management. But you gave me a somewhat broader title for the talk, and to also talk about the future of cardiology and potentially expanding roles of cardiac CT. And in this context, it's good to take a step back and look at what cardiology has been able to do in the past decades, because cardiology really has been a success story. Here's some data that was published 20 years ago, looking at the increase in life expectancy in the United States. And you can see that the life expectancy in the United States between 1970 and 2000 increased by approximately 7 years. And more than 4 of the 7 years of average life expectancy that has been gained was because of better management of cardiovascular disease. Better management of cancer led to about 3 months of average life expectancy gain. Avoidance of injuries and perinatal disease gave all approximately 3/4 of a year. But the better management of cardiovascular disease was the main contributor to the increase in life expectancy in the US between 1970 and 2000. And the majority of this because of better management in all along the entire spectrum, better management of coronary heart disease. If you look at the mortality of myocardial infarction, you know this very well. Initially, the mortality for STEMI was 30%. Then the invention of defibrillation and the provision of hemodynamic monitoring for patients with STEMI, the coronary care unit introduction reduced mortality by 15%, 15 absolute percent, 50% relative reduction. Reperfusion gave another 8% decrease of mortality. Doing PCI gave another 2 to 3% absolute decrease in mortality. And this is where we are today in the 4 to 5% range mortality for STEMI. But in spite of these tremendous improvements, cardiovascular disease remains the #1 cause of death across the world. Here you can see the data from, I think, 3 years ago, 18 million deaths caused per year globally by cardiovascular disease, about 85% of them due to coronary artery disease and stroke. And the second leading cause of death, cancer, 9 million deaths, cardiovascular disease, 18 million deaths around the world. And it's actually expected that this number will increase rather than decrease as we go along. Here you can see the development between 1990 and 2013, where we're, in spite of our better management of cardiovascular disease, 12 million deaths in 1990, 17 million deaths in 2013, for an increase of 41%. Now, why is there an increase if our management becomes better? Well, this is #1, the increase in population. The world's population is growing, so we have more cardiovascular deaths. #2, the population is aging. And aging, of course, contributes significantly to cardiovascular mortality. This is a plus of 55%. Subtracting 40% for better management leads to the increase of 41% in the number of cardiovascular deaths. So the burden of cardiovascular disease will undoubtedly continue to increase because of the growth of population and mainly because of the aging of the population. Here's the distribution of the population age in my country, in Germany, in 2015. And this is the change. We have 21% of individuals in our population older than 65. Very few are born, as you can see here. And in 2040, we will have 1/3 of the population older than 65. So tremendous changes to be expected. And we know that there's an exponential increase of many heart diseases with age. Mitral valve disease, for example, aortic valve disease, atrial fibrillation. We call them degenerative heart diseases. They become exponentially more frequent with age. So a slight increase in the aging of the population will lead to a tremendous increase in the number of patients with cardiovascular disease of degenerative nature. So the trends in cardiology are easy to predict. There's most likely for the next several decades before we have, vaccinations against atherosclerosis and all of these things. But for the next several decades, a tremendous growth in disease burden The switch probably from mortality, sudden cardiac death to myocardial infarction, more towards chronic morbidity. The switch of diseases from coronary artery disease that we learn to treat better towards the more degenerative heart diseases. And because of high cost problems, a tremendous problem with resources to take care of all of these patients. And while this might have been the typical heart disease patient in the 1970s and 80s, currently, at least in my country, this is the typical patient, not this, but this is the typical patient with heart disease, the elderly lady with heart failure and numerous comorbidities. At the same time, of course, cardiology is going through a tremendous development. We have tremendous improvements in interventional cardiology. We have much better medication also, but in interventional cardiology, we are challenging surgery in many respects for coronary artery disease and outside the coronary arteries. And also we're finding solutions for the very sick and the very comorbid patients. These are the trends that we see in cardiology. In comorbidity, frail patients, very sick patients are becoming the routine. Here you can see among patients who have heart failure in the United Kingdom, they have very close registries of what is happening with their patients, and they can collect tremendous numbers of patients and characterize them very well. Here are 4 million patients in the United Kingdom who have heart failure, and you can see the number of comorbidities they have. And while in 2002, 20 years ago, the majority of them, 75%, had up to 4, between 1 and 4 comorbidities. Now, only 25% have 4 more comorbidities or less. And many of them have 5, 6, 7, 8 comorbidities. Patients are becoming sicker and sicker, patients with heart failure here, for example. So the trends in cardiology, we will have increasingly difficult patients with multiple diseases. Because of the resource problematic, we will have a requirement to target expensive therapies to those who benefit most. And also because we have complex interventions that challenge low-risk surgery, we have to control the risk and make sure that the interventions that we cardiologists do are really low risk and are able to provide the same outcome or better outcome than surgery. All of this can be summarized as a need to do personalized medicine, really target our management to the individual patient. Now, CT in a number of areas has tremendous potential here, targeting the best therapy to the patient who needs it. In the area of coronary artery disease, as I highlighted before, the ability to identify patients who have plaque but no stenosis might allow us, those patients who need intensive lipid therapy, to prevent the first myocardial infarction. And again, registry data retrospectively shows that statins are useful to reduce event rates in patients who have plaque. Statins are not useful in individuals who have no plaque. So in the coronary artery world, CT to target the therapy to those who need it most. And in fact, the potential of high dose and effective lipid lowering therapy to change what we do with our patients in cardiology is tremendous. Lipid lowering, tremendously strict and effective lipid lowering is really a game changer and will continue to be a game changer in coronary artery disease. This is why we are seeing fewer cases of coronary artery disease in Germany, because the cholesterol levels are going down in primary and in secondary prevention. And if you look at the ischemia trial, where we were all surprised to see that revascularization did not change outcome in patients who had stenosis and ischemia. In the ischemia trial, patients had ischemia and they were randomized to invasive or initially conservative. Yes, and angina was reduced very effectively in the invasive arm. There was only a very, very small impact on myocardial infarction. But I tend to say that this is not so much a revascularization trial. This is a trial of high-dose statin therapy, because in both of these arms, in both arms, high-dose statin therapy was given. And I think that this is the main reason why revascularization did not change the prognosis. Yes, the symptoms, but not the prognosis, because these patients were all on very high-dose statin therapy. And again, this is where I think CT will play a role in the future, because it can visualize plaque, it can visualize the substrate that causes myocardial infarction, probably be able to visualize those patients, identify those patients who need high-dose statin therapy. But as the population is aging, as I said, the degenerative heart diseases will tremendously increase because it's an exponential relationship, at least at current times, between age and structural heart disease. And we can see the numbers of MitraClip, we can see the number of the transcatheter aortic valve procedures increasing also almost exponentially as we go along. And this is again where CT will play a very important role, the advanced structural heart interventions. Because again, I'm repeating myself, the ability to look at the heart with very high spatial resolution in any desired plane, and this gives tremendously important information for our structural heart interventions. In the TAVI example, this is where this is most prominent, visualization of the iliac arteries, visualization of the aortic annulus to measure it exactly, visualization of the aortic valve relative to the coronary ostia to avoid coronary obstruction. So these are the areas where CT is currently already used very, very accurately and intensively to avoid vascular injury, to identify alternative access sites if the femoral access is not possible, to allow for very, very accurate prosthesis sizing to optimize the outcome, to help avoid coronary obstruction by exactly measuring the aortic annulus distance to the coronary ostia. Here is a case where the coronary ostia are simply too close to the aortic valve cusps, and there's obstruction, a danger of obstruction here, or also very prominent, the danger of obstruction often in, if you consider TAVI for a valve-in-valve procedure, there's also a problem rather frequently with potential coronary obstruction. So this is what CT can provide, potentially in the future even more, predicting annular rupture, predicting the requirement for pacemakers. So this will potentially also be figured in, but at the moment it's vascular access, prosthesis sizing, and the risk of coronary obstruction, where CT is almost indispensable to prepare for TAVI. But TAVI is also, as I said, moving towards the area where it's competing with low-risk surgery. Initially, it was done in patients who had no other options, the first partner trials, patients who were very high risk, patients who had a limited lifespan. But now, of course, we are considering to expand TAVI as an alternative to surgery in patients who have a very low surgical risk. This is the Partner 3 trial. Look at the low rate of events in patients who have a long lifespan ahead of them. So while initially for the TAVI procedure, it was perfectly okay to accept a certain risk and to also mainly look at the short-term outcome, now as we're trying to expand avoiding surgery even in lower risk patients, we have to make sure that there's minimal procedural risk and that long-term outcome will be optimal. And this is where the CT imaging prior to the procedure will be, and we're already seeing this, tremendously important to guarantee that the procedural risk is low and that the long-term outcome will be optimal. So in the context of these structural interventions, where we do them because there's no other, but also where we consider to use them instead of surgery, CT has a tremendous potential with its ability to provide very accurate planning. Other procedures also rely on CT for planning because of the tremendous capability for visualizing anatomy and function. Cardiovascular tricuspid repair, for example, is just one example of where all the measurements necessary to prepare for the procedure are done by CT. In general, I'm almost done, only 2 or 3 more slides. In general, the information that we get from CT for the structural interventions that we do are, number one, very accurate delineation of the target anatomy. Here's a paravalvular leak in aortic bioprosthesis, and it can be investigated very, very thoroughly by CT to plan the procedure. And then there's a projection, also very helpful in the cath lab, to determine the optimal projection to do your repair based on the CT scan. And you can see if you take this projection, it's very straightforward and easy to visualize the best passageway and to place the occluder. The role of CT as cardiology is evolving, looking to the future. CT is really a central part of a very important development because of its ability to visualize cardiac anatomy so accurately. It's the development to achieve personalized medicine and to contribute to this through precision imaging. The imaging is not the only component, but it's an important component to further have our drive towards really personalized management of cardiovascular disease. The 2 main I predict is, number one, the accurate diagnosis of coronary artery disease, both in symptomatic patients regarding the presence or absence of stenosis, but also potentially the quantification and characterization of plaque to identify patients who will benefit from a very intensive lipid therapy, potentially over a very long period of time. So that's potentially expensive therapy that we need to target to the patients who really need it. And making structural heart interventions effective and safe is a tremendous growth area for CT. And with this, I would like to thank you very, very much for your attention. Thanks a lot.
Thank you so much, Dr. Achenbach. That was spectacular and an amazing summary of 20 or 25 years of development of cardiac CT that you have definitely lead with other investigators around the world. I'm going to introduce one of our interventional cardiologists. I didn't have a chance to introduce him at the beginning because he was in an intervention, but his name is Hernando del Portillo, and he will be co-moderating the session of questions. You're mute.
You have to unmute Hernando.
You're mute.
Okay, thank you,
much
Dr.
better.
Okay, it's better. Okay, thank you, Dr. Achenbach, for this excellent presentation. You're like an idol for our cardiology generation, not only in Twitter. So for me, it's more than a pleasure to be here. We will continue with the questions and answers sessions. I have one. Recently, Dr. Patrick Saruis presented the rationalization of the fast track study to start to do coronary artery bypass graft surgery in patients with 3-vessel disease with angio-CT without coronary angiography. Which is your opinion about this trial? And do you think it is the future?
Well, we hardly ever send patients directly from CT to bypass surgery. We have done it occasionally, but usually the patients who end up in the CT scanners, as I said before, are in the low to intermediate risk. So the likelihood that you really find triple vessel disease is relatively low. The patients where we identify stenosis typically have 1 or 2 lesions, and then we will take into cath lab and do revascularization there. I think if image quality is good enough, it's absolutely no question that CT can be the basis for surgical revascularization. I do not see this so much as a very, very large stream of patients, because the patients who typically end up in the CT are not the triple vessel disease patients. And even in triple vessel disease, I have to say that there are quite a few where the revascularization is not very complex, where we now do the revascularization also interventionally. So yes, of course, the data is there, and we all admire Patrick Saruis and his group. But for the real clinical situation, this is not a very frequent patient, I would say, that this really applies.
Thank you, Dr. Achenbach. Dr. Medina, do you have a question?
Yes, I'm going to combine a couple of questions, one from our cardiology chairman and one from my partner in crime here, Dr. Forero, who's a radiologist who reads with me and the rest of our group, CT. What's your opinion about FFR and CT versus perfusion CT? Ron Blankenstein from our group at MGH published in 2009 the first perfusion CT, and then FFR got momentum, and now it's kind of the way to go. It's the new, like the new kid on the block, not so new. That's the first question, your FFR or go back to perfusion. How do you see the future? And the second, the part B of the question is, these are very, very expensive technology. It's not available for most centers. And also specifically in Latin America, it's a very, very high cost, particularly FFR. How do you think we can make it more universal, the access to this type of technology?
Yeah, well, the first, I would like to comment CT myocardial perfusion. I think it's underused. The data is pretty good. The diagnostic performance, if it's done well and interpreted with a bit of experience, seems to be very similar to the other perfusion tests that we have. The problem, I think, with CT perfusion are more the practicalities. Typically, CT has the beauty of being a very fast test. You can schedule a CT every 10 or every 15 minutes and simply move the patients through. Then if you suddenly decide that you want to do perfusion scan, you need to, typically take the patient off the table because the next one is waiting already, and you cannot do it ad hoc. And if you want to schedule a CT scan for perfusion, you have to set aside half an hour or 45 minutes. And then, at least in our institution, if you do an elective scan, rather do MR perfusion imaging, because there's no radiation and the no nephrotoxic contrast and so on. So it's more the practicalities, I think, that have so far avoided that CT perfusion picks up more. The data is rather convincing. And with dual energy scans and things like that, probably it will become even better. It's more the practicalities. FFR-CT, I have to admit that I'm not a big fan of FFR to begin with, even in the cath lab. It's occasionally a useful tool when you really want to make a decision in a situation where the symptoms are unclear, the lesion severity is unclear, and you desperately want more information. But basically what FFR, if you look at the data, it's not very strong. You can defer revascularization based on a normal FFR, but to be honest, you can probably defer most revascularizations and people won't drop dead. It's really revascularization helps with symptoms. And if you do revascularize based on FFR, you avoid a few acute late revascularizations. So the effect of FFR is a bit overestimated, I think. We do about 400 to 500 FFRs in my cath lab. I'm not such a big fan. Now, non-invasive FFR, it's the same problem. What do you do if non-invasive FFR is negative or just a little bit above the 0.8 threshold, but the patient has chest pain? So you want to help these patients. And I'm not such a big fan of FFR. And this eliminates question part number B, which is the cost. Because we don't do it a lot, the cost is not such a big issue. But we know that FFR can also be done with programs that are cheaper. It's just the patent situation that currently requires FFR to be done just by one company and make it very, very expensive. But I think after a while, either as this is rolled out more broadly, or as other companies are also going on the market, it will probably become cheaper.
Okay, thank you. Fernando, please.
Okay, we have another question here. It is no doubt the utility of the CT for TAVR now for the mitral valvular procedures, but what do you think to use of CT for planning the tricuspid valve procedures?
But at the moment, there's such a big spectrum of tricuspid valve procedures which are being considered. But the beauty of CT in no matter what is the very accurate measurements that it allows. The measurements of the dimensions of the very irregularly shaped valve, assessment of right ventricular function, assessment of the coronary arteries relative to the tricuspid valve. So my prediction is that we will use CT very heavily for all kinds of tricuspid valve procedures that are currently being discussed. The clipping procedures, whether it's Pascal or mitral clip, whether it's the mitral valve or the tricuspid valve, they usually don't rely so much on CT because clipping is not so much dependent on the overall anatomy. But all the other procedures use CT rather heavily for planning because they require the very exact anatomic measurements. So anything that is not clipping, I think that CT will become really, really a mainstay. Will it remain forever? I think all the other technologies are also making progress. So who knows whether maybe 10, 15 years from MR will be able to give us, 0.5 millimeter resolution in all dimensions. And then the situation might change. But at the moment, CT really has an edge as far as the accuracy of the images is concerned. And this is why I see for a while CT to be the driving force in planning all of these structural interventions.
Thank you. Thank you, Doctor.
I have a question from our CCU director, and also a question of one of our fellows. First question is, in what specific condition would you consider a patient or initiating a patient or the strategy in those who are 65 years old or older? Because the ACC/AHA guidelines are mentioning that in those type of patients, maybe CT is not such a good strategy. And the second question is, have you seen an increase of the use of the CTA since the publication of the ischemia trial?
Well, we have not seen an increase here in the institution or our area because we've used a lot of CT even before the ischemia trial. And CT in the ischemia trial was really much more of an inclusion criterion than it was something that was evaluated within the trial. So I did not see a lot of impact in my area that I oversee of the ischemia trial on the use of CT. For the second question, whether there should be an age cutoff to use CT, we use CT, in the 75, 80-year-old patients, as long as they have no prior revascularization and as long as they have sinus rhythm, then typically we use CT irrespective of the age. Of course, with increasing age, calcifications become more prominent and you might run into problems. In our TAVI population, we have a look at this coronary arteries, even though we don't do a coronary scan, and sometimes they're very calcified, so we need an invasive angiogram anyways. But age per se is not a reason that you should do another test rather than a CT scan.
Okay, Fernando, go ahead. We have a few more questions, few more minutes before a whole hour.
Okay, yes, we have here a question. Okay, the deployment of the transcatheter aortic valves creates a unique anatomic geometry generating a displacement of native valves, dividing the native sinus in two structures, anatomic sinus and new sinus. Do you think that we need to evaluate 5 or 10 years after TAVR these spaces, especially the anatomic sinus where there are a low flow velocity and a knee vortex? Could this be related to durability?
Well, there is, of course, thoughts that the turbulent flow or the stasis that are caused by generating a new sinus. Nature is fantastic, right? They have generated the sinus and the aortic, everything in a shape that is perfect for slow. Even the fact that we have 3 cusps of an aortic artery up to minimize turbulences is really amazing. And by placing a prosthesis in there, we destroy everything. And currently, however, there's absolutely no rationale for routine follow-up of the TAVI or TAVR procedure with CT. There has been initially the idea that maybe the halt, the thrombus formation might be good if we try to detect it routinely by CT, but then there was no association to clinical events, even if we see halt. And as far as valve durability is concerned, I think we should simply do echoes and see whether a gradient occurs. So at the moment, the data that we have does not really suggest that a routine follow-up CT scan is necessary.
Okay, thank you, Dr. Medina. Do you have another question?
Yeah, there's one question about weight. In your publication from the Flash almost 10 years ago, I think there was a 50-patient cohort with optimal heart rates, and I remember that was the sub-millisievert famous publication you made. It was probably the first publication ever done, and at that time you mentioned weight as one of the ideal kilograms. I think it was 80 under you should optimize.
That was for the very low dose protocol, like ridiculously low dose protocols. That's where we had 80 kilograms as a cutoff. I would currently say for a current CT scan, probably 120, 125 kilograms is the area where you should start thinking whether another test might be better. Invasive angiography always works. Don't forget this, right? Invasive angiography is very robust. But it also depends on how desperately do you want to avoid the invasive angiogram. If you have a patient, for example, with endocarditis and huge vegetations on the aortic valve, and the patient weighs 145 kilograms, I will happily do a CT to avoid the cath. So it really depends on the patients that you're seeing. But to cut things short, I think up to about 120 kilograms, 125 kilograms, image quality will not be severely degraded by the body weight. Above this area somewhere, it becomes more problematic. It's also a question, where is all of this weight, right? If it's a 2-meter person who weighs 120 kilograms, it's very nicely distributed and it will not get in the way of the CT scan. If it's a person who is only 140 centimeters and he or she weighs 120 kilograms, it's probably all going to be in the center of the scan. So it really depends a little bit also on the distribution.
Okay, and the final question that I'm getting on a couple of questions on the private chat, because we have to deactivate the chat of our, we had someone kind of bullying us on Zoom. It's about mitral and TENVR. We had Jonathan Leipzig last year talking about it, and also we'd love to know your opinion about if you think CT is going to become as crucial for TENVR planning, both for native and valve-in-valve intervention as it is for TAVR. And do you think being both a CT person and interventionalist if this is going to take off from the floor and change the whole spectrum and the paradigm of disease treatment in the mitral valve as it has taken for aortic valve.
I think it's fair to predict that whatever strategy we need to transcatheter placement of mitral valves, I'm not talking about the clips, we need extremely exact assessment of the anatomy. And at the moment, for truly isotropic visualization, CT is unbeatable. So I think CT will be super important for mitral valve prosthesis, just as for tricuspid valve prosthesis. That's my prediction. At some point, I said this earlier, very far down the line, maybe we have volume echocardiography or very high resolution MR that will do the job. But for the foreseeable future, I would think that CT remains the mainstay to plan these prosthesis, transcatheter prosthetic procedures.
Okay, thank you so much for a very, it was absolutely spectacular to see you again in person. It was an honor for us to have you.
My pleasure. Thanks a lot.
And we appreciate also being so late in Germany and you're staying a little up late for this presentation. And we hope that we can, visit you guys in Barcelona. Of course, you're the chairman of the ESR session. So hopefully some of us can enjoy the meeting.
It would be so nice, if we could meet in Barcelona.
Absolutely. Have a good night, sir. Thank you so much again. And thank you for everyone for assisting to our conference. Gracias,
Thanks
Hernando.
a lot. Bye-bye.
Thank you. Thank you.
Adios,
Bye-bye.
I think we say. Yes, bye-bye.
Adios, doctor.
Bye.